Hey guys, welcome to case 2 in our video series. This is going to be a GI case. We're going to discuss a little bit of liver, a little bit of gallbladder. Alright, so let's get into it. So we have a previously healthy 3-year-old girl brought to the physician because of a 5-day history of yellow skin. Okay, she also has loss of appetite, 4 episodes of vomiting. Mother reports darkening of urine and light stools. During the last 2 days, the girl's been scratching her arms and abdomen and is irritable. Okay, itching. She was born at 38 weeks, gestation with uncomplicated pregnancy and delivery. Immunizations are up to date. Vital signs are within normal limits. Examination shows jaundice of the skin and the sclera. Abdominal exam shows a mass in the right upper abdomen. Okay, so we have a 3-year-old girl, and let's say for the case of this case, this girl is a Cambodian girl, and I'll discuss why this detail is important in a little bit when we discuss the answer choices. Okay, so we have our serum studies here. Her bilirubin is elevated at 6, with direct of 4.7, so this is mostly a direct hyperbilirubinemia. Then we have an AST of ALT, really unimpressive. Maybe the ALT is a little high, but not really something crazy. And then we have GGT that's 115, so this one we're looking out for. GGT, of course, is our cholestasis indicator. Then our abdominal ultrasound. Here's our big boy. This is what's really going to help us answer the question. Shows dilation of the gallbladder, fusiform dilation of the extrahepatic bile duct. Okay, so what's the most likely diagnosis? I'll give you a second to read over the answer choices, and you can pause the video now, and then we'll go over each answer choice. So if you answered biliary cyst, you are correct. Now, we clearly have a cholestatic pattern here. This girl is jaundiced, she's itching because of the high bilirubin accumulating in the skin. We have a direct hyperbilirubinemia. Okay, we have a cholestasis from the GGT indicator, dilation of the gallbladder, and fusiform dilation of the extrahepatic ducts. So let's go through each answer choice and discuss them. So biliary cysts, also known as choledochal cysts. These cysts dilate the biliary tree, right? And when you have a dilated biliary tree, the flow is ineffective, so you're not going to be able to drain your conjugated bilirubin very well. So this mostly happens in people of Asian descent, okay? So this is why I mentioned our girl was Cambodian, because that's a country in Asia. These can be saccular or fusiform. Now, what does that mean? So here we have on the right our diagram of different types of cysts. Now, saccular cysts are cysts that kind of pouch out of the main tree, and fusiform cysts, you can see they're part of the tree. So fusiform would be like type 1, and saccular would be like type 2. Now, there's 5 types. Knowing the exact types is a bit low yield, but type 5, as we'll see with one of our answer choices, is associated with Caroli DIsease. So we'll discuss that when we get to it. So we have, in our case, we have involvement of the cystic duct, and because we're seeing gallbladder dilation, so the cystic duct is being either compressed or involved with this biliary cyst, and therefore it cannot release the bile, so our gallbladder is just inflating and becoming dilated. It's filling with bile but can't empty it. If it's untreated, we can get cholangitis because when stuff isn't moving, bacteria likes to invade, and cholangiocarcinoma because chronic irritation in that area can cause cancer cells to proliferate. Then we have treatment, which is surgical excision. You want to remove that cystic area, and then you can do a sort of Roux-en-Y to reconnect everything. Our next answer choice is Murizi syndrome. Murizi syndrome is caused by a bile stone lodging in the cystic duct, as you can see here on the diagram to the right, and then this compresses the common duct. Alright, so we have a cholestatic pattern, just like we saw in our patient actually. And we have dilation of the gallbladder and the extrahepatic bile duct. So why is this the wrong answer? This is rare in children. You're really not going to see it in a child. And the only way you'd potentially see it as a child is if you have hemolytic anemia. Let's say you have a hereditary spherocytosis and you're getting gall stones formed from the hemolytic side of things, but unless they give you this detail, you really have no reason to choose Murizi syndrome for this child. Next we have biliary atresia. This is a very famous thing you got to know about in your peds. This also causes a cholestatic jaundice pattern. But this usually presents within the first few weeks of life. Our kid here is well into the years, right? So unlikely. And then ultrasound, you're going to see atresia of the extrahepatic bile ducts and a small or absent gallbladder. So this is an extrahepatic pattern, but you're not going to see dilation. You're going to see atresia, which means they're not going to be there. And how do you treat this? Well, it's the Kasai procedure, where essentially, because the extrahepatic bile ducts aren't there, you're shaving down the liver till you hit the intrahepatic, get some bile flow, and then you connect the small intestine right to that, and then you reattach the stomach to the small intestine also. But the problem with the Kasai is it often fails, and then these kids need to go to transplant anyway. Alright, next. Caroli syndrome. So Caroli syndrome, as we saw with the type 5 cysts, we have a cholestatic jaundice pattern. This is an inherited dilation of the intrahepatic bile ducts. So in our picture, we had an extrahepatic picture. In the ultrasound, this is intrahepatic. Alright, so the gallbladder and extrahepatic bile ducts would not be dilated, and you'd see multiple saccular dilations intrahepatic. Okay, so that's how we differentiate those answer choices for Caroli. Caroli, intrahepatic cysts. All right. Then we have hepatic abscess. So what is the evidence that could lead us to this? So we have nausea, vomiting, maybe anorexia in this case, but really this does not point you at all to hepatic abscess. Where's the fever, right? Where's the pain? Right upper quadrant pain, tender hepatomegaly. AST and ALT would also be a little higher. You wouldn't have those low values. And then again, it's way more common in adults, especially those with risk factors such as diabetes, underlying liver disease, immunodeficiency, amoebic dysentery if it's gone on for a while. Alright, so that's hepatic abscess. Really not what we're looking for. Allagille syndrome. Okay, this is another one of those congenital syndromes, not very common, so we don't really talk about it. This is a congenital intrahepatic biliary duct aplasia. Okay, so imagine we talked about biliary atresia, right? That's an extrahepatic atresia. Allagille syndrome is an intrahepatic atresia. Right, so it's an intrahepatic aplasia or hypoplasia. You're not going to see those intrahepatic ducts. This would present again in the early stages of life, and you would not get that right upper quadrant mass that we got with our cyst. So we saw that on our physical exam. You wouldn't see that because this again is an intrahepatic thing. You would get the cholestatic jaundice though. So again, 6 months early on in life, and it's associated with other congenital anomalies. So it's not going to come with the liver findings on its own. Broad nasal bridge, triangular face, deep set eyes, heart defects, those would be associated, so they'd probably give you another detail if they wanted to really point you to Allagille syndrome. And then finally we have type 2 Crigler Najjar. So Crigler Najjar, as you know, is UDP glucuronidase deficiency. Type 1 versus type 2. Type 1, there's no activity. Type 2 is just reduced by a lot. Then we have, in this case, we have jaundice of the infant, and you'd get an unconjugated hyperbilirubinemia. So that's where it diverges, because our bilirubinemia was direct. So direct is conjugated, so not the case here, right? Also, you wouldn't really see features of cholestasis because there is nothing blocking the bile flow. It's just the conjugation that's gone wrong. So the pruritus, the acolic stools, the dark urine, the light stools, the dark urine, you wouldn't really see that because this is not a flow problem. This is a conjugation problem. And just another tidbit about this, how do you treat it? Phenobarbital induces UDP glucuronidase, so you pop them on a barbiturate, and then you'd also use phototherapy, which you definitely use for Crigler Najjar type 1 as well. Now phototherapy makes the direct bilirubin more soluble. It doesn't conjugate it, remember? They might put that on stress to trick you. It just makes it into a more soluble form, not conjugating it. Alright, so I hope this case was a little bit fun, a little bit helpful, and I'll see you in the next case. Thanks for listening.